So the next presentation will be presented by Dr. Яневска. The name of the presentation, Interventional Treatment of Chronic Visceral Ischemia.
Hello, I will be present for interventional treatment of chronic visceral ischemia. Echo Doppler diagnostics of visceral arteries, verificate normal Doppler findings of visceral arteries, proximal abdominal aorta and inferior vena cava in cardiovascular disease, stenosis and occlusion of visceral arteries, arterial aneurysm, arterial pseudoaneurysm, arterial dissections, compression syndrome of visceral arteries and arterial venous fistulas. Conditions leading to difficult visualization of the visceral arteries are obesitas, dyspnea, shadows of arterial calcification and elongations, and arrhythmias. Stenosis of celiac trunk. The stenosis of celiac trunk may be asymptomatic thanks to the collaterals created by superior mesenteric artery or the congenital anastomosis of the visceral circulation. Stenosis of celiac trunk can be formed by atherosclerotic plaques, aortoarteritis, compression syndrome from malignant and benignant formations, and Dunbar syndrome. Different types of stenosis of celiac trunk are atherosclerosis, fibromuscular dysplasia, and Mal's syndrome. Stenosis of mesenteric artery is in the ratio woman to man 3:1 with symptoms pain after eating, weight loss, bloating, diarrhea, and gastroparesis. The stenosis of mesenteric artery are often asymptomatic. Significant stenosis are found in 14 to 24% of patients after abdominal angiography. Progression of symptoms, symptomatic intestinal ischemia is about 15%. Visceral or mesenteric ischemia, acute and chronic, mostly caused by often embolism. Most common affects CMA, osteoproximal stenosis or occlusion, thrombotic occlusion, previous symptoms of chronic myocardial infarction or another atherosclerotic manifestation. Powerful collaterals of the mesenteric circulation, celiac trunk and lower mesenteric artery reduce the risk of interstitial infarction, elevated dimer and lactate in intestinal ischemia, immediately life-saving revascularization, and complications are peritonitis and septic shock. Early signs and symptoms of acute mesenteric ischemia in 80% of cases include several abdominal bulk, nausea and vomiting, melena, history of chronic atrial fibrillation and cardiovascular disease, peripheral atherosclerosis. The guideline recommendation places class 2 the endovascular therapy as first-line method of revascularization. Also, both endovascular and surgery therapy should be considered. Chronic ischemia, stenosis of chronic occlusion of the celiac trunk and mesenteric arteries, atherosclerosis of the aortoiliac segment in 20%, vasculitis aortoarteritis in young patients, fibromuscular dysplasia, compression syndrome, and AAA. Paraclinical studies, anemia, leukopenia, electrolytis abnormalities, and hypoalbuminemia. Symptoms of chronic mesenteric ischemia, postprandial abdominal pain, weight loss, loss of appetite, fear of eating or changing eating habits due to pain, nausea and vomiting, constipation or diarrhea, and history of cardiovascular disease. Treatment are endovascular and treatment and stent implantation, and intraarterial fibrinolysis, thrombectomy, bypass surgery, anticoagulant therapy, and antiplatelet therapy. Protocol for visceral interventions is 6 French right brachial approach, 6 French radial Judkin guideline catheter, 0.014 coronary wires for the pre-dilatation coronal balloon and balloon expandable peripheral stent. Endovascular treatment of visceral ischemia acute and chronic in cardiovascular center, City Clinic, for a period of 8 years is 238, 123 for celiac trunk, 103 for superior mesenteric artery, and 12 for inferior mesenteric artery. Primary patency for 1 year, 1 year is in 80%, secondary patency at 18%. The first clinical case is male, 61 years old, after successfully isolated AAA with wall stent implantation, clinical presentation with abdominal pain, heaviness, reduction of body weight 7 kilos in 3 months, with risk factors for atherosclerosis, dyslipidemia, arterial hypertension, lead smoker. For color Doppler ultrasound, the result is critical stenosis of celiac trunk in first picture and 70% stenosis of superior mesenteric artery in second picture. This is a result of CT angiography with the same result. This is the angiography crossing the hydrophilic catheter and predilatation with NC balloon using catheter extension. And this is the result after balloon dilatation. This is a stent implantation. And final result. The second step is stenting of superior mesenteric artery. With stent implantation. And final result. The second clinical case is a male, 49 years old, with comorbidities diabetes type 2, dyslipidemia, arterial hypertension, chronic gastroduodenitis, and smoking. Clinical case, abdominal pain, postprandial heaviness, reduction of body weight 30 kilograms for 6 months, nausea, diarrhea, and pelvic claudication pain after 200-meter walking distance. The result of the ultrasound diagnostic is occlusion in left superior femoral artery, distal segment, celiac trunk, and superior mesenteric artery. Critical stenosis are in left external iliac artery, inferior mesenteric artery, and left and right renal arteries. Ankle brachial index in patient in right side is 0.9, in left 0.5. This is a visceral artery diagnostic with pathology and diagnostic of inferior mesenteric artery with predilatation in inferior mesenteric artery in this slide. Stent implantation, Herculean lesion. After stent implantation in inferior mesenteric artery and visualized blood collateral flow in celiac trunk and mesenteric artery. Next step is stenosis of renal artery and stent implantation in left one. With final result, this. And next step is the same pathology, but in right one. Now, this is the final result. And the next step in a patient was performed peripheral revascularization. The third clinical case is male, 91 years old, clinical presentation with abdominal pain, heaviness, reduction of body weight 17 kilograms in 9 months, with risk factors for atherosclerosis, dyslipidemia, arterial hypertension, and smoker, comorbidity after coronary artery disease and bypass surgery, after TAVI implantation and VVI pacemaker, previous performed endoscopic examination without significant pathology. The ultrasound diagnostic is occlusion in two lesions, superior mesenteric artery and celiac trunk, and critical stenosis in inferior mesenteric artery. This is angiography for total occlusion of celiac trunk and superior mesenteric artery. The second one is placement of wire in inferior mesenteric artery and dilatate critical stenosis with stent implantation. Final result, we see the collateral to superior mesenteric artery. Next step is crossing the occlusion with coronary CTO wire in celiac trunk and implantation, the stent Hercules in this occlusion, and this is the final result in celiac trunk. Final result for this patient in a follow-up examination 2 months after the intervention. The patient is without complaints, without abdominal pain, with normal food intake and weight gain. Conclusion are diagnostic and treatment of chronic and acute mesenteric ischemia, prevent dangerous life-threatening conditions. The highly specialized diagnostic method, color, Doppler ultrasound, and CT angiography are affordable and highly effective. The effectiveness of endovascular treatment is life-saving with low procedural risk and good long-term result. Thank you for your attention.
Any questions from the audience? I do have a question about the first case. So you used 2 wall stents, one in another, to isolate the aneurysm? Like
yes, before,
right?
before
okay.
10 years. Yes.
Oh, okay, yeah.
Yes. And this is a second.
Sure what was the purpose of that? But okay.
Yes, AAA isolate.
Okay.
Yes.
And my another question is, for example, if you have patients with severe stenotic lesions of all 3 vessels, how many arteries do you treat? Just one, or all 3, or what do you prefer? What's your protocol?
The difference is the patient have a good collateral blood for celiac trunk or maybe for mesenteric inferior artery, and in the third case, in a celiac trunk don't have a collateral, and the second step is recanalize and celiac trunk.
So I want to ask you the same question about the follow-up. How do you follow up those kind of patients?
Follow-up, the first is ultrasound Doppler, when we have a patient with extreme obesity or more calcification and another problems to not visualize with ultrasound. We make some CT angiography, visceral angiography to make some check in this segment. If paraclinic is okay with creatinine, urea, and...
Thank you.
Thank you. Other questions?
Thank you.